ocean, ma'am. It looks like an ocean. It is
Ocean.
you turn
Yes,
the
it
page,
must
it's
look
coming
like.
on.
Yes,
So many.
yes, I can imagine that. With the stress of exam and all that, of course, it will look like and it will feel like an ocean, and you're diving in and you're thinking, what am I doing and what am I? So my tip for all of those people who still have 2 days in the exam is that please just go through the, the question stems and make those little bubbles that you think are very useless bubbles, but they are actually very useful bubbles. Please just, just keep running through. You don't really need to be practicing like mad, okay? Like trying to say things in 10 minutes. Please stop that rehearsal and do what I'm saying. Anybody doing the way I asked you guys to do? Yeah, go through the questions quickly, make small bubbles. Anyone doing it like that?
Ma'am, I'm doing, ma'am, especially the management part.
Everything,
Even
Manika, good.
yes, ma'am.
Yeah, not only management. Like for instance, if you're thinking of, let's suppose you're thinking of a topic pregnancy.
Yes, ma'am.
Just you're reading the question and thinking, what can she ask me? She can ask me about the management. Yes, she can ask me about the future fertility issues. Yes, what is it that I'm going to tell her? She can ask me about, I will have to tell her about the red flags in case she is going home and on a conservative management. So you're thinking on so many things, isn't it? Then maybe contraception as well. Maybe she was not having contraception and that's why she. So there are all those things that you'll be thinking. And you are quickly making bubbles that these are the things that, and you will find things that you think that, oh, I must look into this aspect because I don't know this aspect. Just like Nusrat asked, do you need MDT for, duloxetine? So no, MDT is required for the invasive management. So these are the points that you should know now. I mean, you can't be practicing like, that audio practice like fools.
Beginning.
This is not the time, okay? This is the time that you know your answers. You know the best management. People say that we were in the exam and the role player was not satisfied and they were getting angry and all that. That happens because you don't have that good answer. You don't know the solid answer that you should be giving them. Role player only gets annoyed because of that, okay? Yeah. So any one of you stuck with anything, please come up now to tell me now, and let's quickly go one by one through your questions and make your life a bit easy if we can.
Hello,
I'm a patient with this positive HRHPV. Does she need any referral to gum clinic, ma'am?
Say it again. Patient with what?
HPV positive.
HPV positive patients, they don't really need if they. So that will depend on their risk factor. Like teenage girls, if they have, if they had unprotected sexual intercourse, and teenage girls are anyway at high risk, there's no harm in saying that if you had unprotected sexual intercourse, we recommend that you get screened for sexually transmitted infections. It will be, this is to stay on the safe side. Otherwise, if you think practically, then HRHPV is so common that it's not really classed as a sexually transmitted infection, is it?
Okay. Thank you, ma'am.
Yeah. Okay.
Hello, ma'am.
So, yes,
Can
hi,
I ask?
Tanya.
Yeah.
Sure.
If a diabetic mother at 36 weeks has a 4.5 kg baby or 4.2 kg baby, what will be the timing of delivery?
Okay, so you answer this question for me. You answer this question for me. Quickly, come on. What do you think is the timing of delivery, Tanya?
Actually, ma'am, patient if wants to go for vaginal delivery now for 4.5 kg, then I can ask her to go for elective cesarean section after at 38 weeks.
Okay, so anyone else wanting to improve on the answer from Thania? Just give me a bit more details. Manikam, do you want to try?
Usually elective cesarean section is done 39 plus 0 weeks, ma'am, after 39 plus 0 weeks.
So, okay, but what about the nice guidance on diabetes in pregnancy? Tell me according to that, what are you going to tell this patient?
Uncontrolled diabetes.
Anyone with the type 1 and type 2 diabetes, we will aim to deliver between 37 to 39 weeks if it's uncomplicated. Okay.
Yes, ma'am, uncomplicated.
Only for uncomplicated. Who's that cute sound? Okay, so in uncomplicated only between 37 to 39. But if there's complication, then it may be decided earlier than that. Okay?
Before 37, yes, ma'am.
Yeah, it can be. It will be then whenever you have to decide before 37, you'll say that I'll get my consultant's input because this, we are here, and mention the nice guidance. Say because as per national guidance, we should be delivering type 1 and type 2 diabetes between 37 to 39 weeks in case this is uncomplicated. But
ma'am, if GDM, we have to deliver before 40 plus 6, ma'am.
That's GDM, yeah.
Yes, ma'am.
That's GDM. 41 weeks is the ceiling for the GDM.
But before we have to deliver that. So after 38, we can go for delivery, ma'am.
But if the baby's weight is already 4.5 kg, after 38 weeks, it will be havoc during section.
Yeah, you have to, absolutely, you're spot on, Atya. So you have to see that how many weeks she is and what's the weight of the baby. And you have to extrapolate that in your head that, okay, this is the weight at this gestation, so we are expecting it to increase. Now, this can put you in the, in the danger zone of that shoulder dystocia and all that. So we are saying that, okay, this can give rise to complications. If the weight is going more than 4.5 and you have diabetes as well, then there's a high risk of shoulder dystocia. So I am going to discuss the option of cesarean and versus vaginal delivery with you. Just to help you decide, but never say that, you after giving options, don't say, well, it's not my decision, it's your decision, you decide. No, you have to tell her recommendation as well. Okay, some people I've seen, they end up just saying that it's your decision. So there is a recommendation. We are medics, isn't it? We give recommendation as well. That as per guidance, what's the safer approach as per recommendation. So we'll say that if the weight is going above that, in diabetes over 4.5 kg, the recommendation is this, that we offer you that cesarean will be safer. Yes, yeah. But of course, that is the recommendation. You have to understand the recommendation doesn't mean that her autonomy is taken away. Her autonomy stays there. But I have seen few of the candidates are so naive. What they do is they give their input, of the options. And when the patient says that, what should I do? They say, it's your choice. So it's not just your choice. It's this is the recommendation. And then, yes, of course, if you have a problem with the choice, then we can listen to your, suppose she gives you an option that you think is extremely dangerous. I'm not going to agree. It's absolutely fine for you to say, okay, in that case, I will need to arrange an appointment with my consultant because I personally feel this is a very unsafe choice. Okay. So the person, the consultant will either be able to convince her or agree to her with documentation or refer her to another consultant who will be able to take the risk. Okay. But this is how it goes. You give a recommendation, pros and cons, then it's her choice. Okay.
Okay, ma'am. And if this patient said that I want to go for vaginal delivery, then already 36, 4.5 kg, then should I induce at 37? To reduce the risk of shoulder dystocia?
So Tanya, I just said that you will need to know that this is unsafe. Okay, you will say that this is something that I will need input from my consultant, and then yes, we will need to decide a date, time for induction, but that requires my consultant input. You can't be that kind of free person to say that, okay, I'll induce you. Then don't do that. That would be unsafe. Okay. Definitely say that.
If 4.2 kg at 36 weeks, then do you need to do another scan? Okay,
Right?
It's may need to do another scan.
We may need, that's it, may is your rescue word. There are few rescues in your exam. One is may, the word may, the other is I'll get input from my consultant. Okay, and there's yet another one that MDT will decide. Okay, so use these, make use of these. These are like free floating currencies there that you can use in your exam and buy some safety for yourself. Okay?
Another word, it depends.
Yeah, it depends on, absolutely. Okay, good. Okay, so yeah. So any more questions? So girls, next question. Who is firing the next question?
DVT patients, a patient had DVT, now wants induction. She just had a DVT, ma'am. Actually, she is planned for DVT for some indication and she just had a DVT.
She's planned for induction for some reason and she wants
Yes.
a DVT.
For IUGR, and she's on anticoagulants.
Okay. And you think that now she is on, okay. So you will have to give her, again, this is going to be an MDT decision, okay? You will say that we need to see the pros and cons and the situation that can we take you to the, you know, we always need to decide risk versus benefits. Before you had this condition, Claire, before you had this DVT, we were only dealing with a small baby and, you know, the risk of prematurity versus the risk of keeping the baby in these circumstances when the baby is not growing. Now we have a third player here, which is your clots in the legs, for which we have given you, are giving you these blood thinning agents. Now, this situation is a bit too complex. The decision needs input from all the MDT. We need to get advice from the consultants who will be able to tell us whether it's safe or should this be delayed. Okay. Whilst on the blood thinning agents, we don't want you to end up risking with, you know, massive hemorrhage, risking your life. If your life is in danger, then same thing happens to your baby as well. Okay, so we need to have a balanced approach here. So I'll get input from my consultant and from the whole team, including the hematologist, you know, looking after this matter, and we'll get back to you on this. Do you think we have said anything scientific here?
And if it is in structure discussion, what will
we
be
say
our
the
answer?
same thing? You will say the same thing, but in a bit of scientific, say that there's a bleeding tendency. We need to monitor her. You know, our first priority is the mother, not the baby. Okay.
Okay. And
so you know that our first priority is the mother. You don't say this to the mother that our first priority is you, but you say to the examiner that my first priority is the mother.
Yes.
I'm not going to risk it. Okay.
Okay.
Right.
And there is always a question in labor board that breech at 8 centimeter, 9 centimeter, undiagnosed breech at 9 centimeter. What should we do? Discuss the plan with patient.
Who is asking? It's Hera. Okay, Hera. So you tell me, what would you do? 9 centimeter undiagnosed breech.
We should ask for the patient, discuss the plan to tell her what could be the options.
What's the gestational age, Hera? What's the gestational age and what's the parity?
We don't know, just they recall the breech in 9 centimeter labor ward prioritization. So maybe
somebody else knows the details. Okay, so this can be a 28 weeker and this can be a 32 weeker and this can be a 38 weeker. Okay, and your answers will depend according to the situation. Okay, so if she was a 39 weeker, what are you going to say? So this is, you will remember, first of all, the bubbles will come into your head. Undiagnosed breech bubble. Okay, this will be for after 37 weeks. The question of undiagnosed breech will come, or even after 36 weeks. Okay, that will be one of your bubbles. Means incident reporting and all that. Then debriefing the patient and trying to see whether this was discovered before. Was she offered ECV or not offered ECV? Has she refused ECV or was it a failed ECV? Okay, all those kind of things. And here you'll say that. You will quickly ask, oh, is she undiagnosed breech? Did we try ECV? Okay, so did it fail? Or did she refuse? Or was she offered a section? So would she rather want to go for a section? Because we do prefer, first preference is ECV, second preference is section, and the third is vaginal breech. Okay. If there's no way that she can be taken for the section and she's refused or whatever, if the section is out of the window, then you will say, okay, so we need we need somebody experienced in breech deliveries to deliver this baby, which will not be an ST3 or ST4 usually, okay? It will be either ST5, 6 or senior or a consultant, okay? Or some departments have got experienced midwives, okay, who are experienced in breech delivery. Don't just say senior midwife, because all the senior midwives can't deliver breech, okay? So you need to say that you need to check, do we have an experienced midwife for breech delivery? No, before asking that, you should say, so this will require either the consultant do the delivery or I can do myself, because you are ST5, you can say that I have been signed off for breech delivery, and then you can say that I'll do it. So let me know around the time of the delivery, give me a shout and I will myself do this delivery. Or do we have an experienced midwife who is trained in breech deliveries? Because some hospitals have midwives, okay? But you need to check that. So what are your issues here? You will need to ask, okay, so are the membranes, gone already, or they're still there? We need to make sure that there's no cord prolapse and all that, okay? What type of breech it is. So it's not footling or anything, so, and all that kind of stuff, okay? So that's it. It's not, should not start getting nervous. Again, I've muted her. So now you tell me your
Ma'am,
question.
premature 32 weeks, ma'am. She's breech and the cervix is 4 centimeter dilated and P-prom.
So you're asking whether she is for section or whether she's for...
Yes, ma'am. That's what.
Give her same options.
Okay, ma'am.
Just yeah, you can't give her, if the membranes are gone, there will be no option of ECV, okay? We can offer her section versus vaginal delivery. If you remember, the green top shies away from seriously recommending. They always say, that because there is a risk of prematurity and death of the baby versus, having an unnecessary hysterectomy in a way. But cesarean delivery is the preferred way, especially after 30 weeks. Before 30 weeks, there's more confusion. If the baby is only like 27 weeks and you're worried that if the baby doesn't survive, am I going to end up doing a section as well? That is a difficult decision, and you won't say anything on that. You'll say, I urgently need to seek my consultant's input on the mode of delivery in her case, okay? But she's 32 weeks, then that's fine. You can offer her section, because 32 weeks survival is very good compared to 27, 28 week and all that. So yes, you give her the option of cesarean, if that's preferred, and then, vaginal breech. Okay.
Thank you, ma'am.
And what else are you going to do? You think that is only about the mode of delivery. No, they are looking at you that, are you thinking about steroids? Are you thinking about other options? Are you thinking about IQ? Have you spoken to the neonatal registrar? Okay. And all that kind of, please be aware that that's very, very important. In brief, the coordinator said that, and she is 28 weeks. So, I'm sorry. I'm sorry, I didn't note that. So I quickly said that I didn't note that. I do apologize. I didn't note that. So yes, I'll talk to the, to the neonatal registrar, check the NICU bed availability. I'll do this, magnesium sulfate, all that, neuroprotection elements and all that, GBS prophylaxis and everything. Then, okay. So please don't forget, that's very important. Okay. So we think, we become tunnel visioned because we're thinking, oh, it's breech. It's only about mode of delivery and all that. No, it's about everything. Definitely look at the gestational age column. So I did this trick with my student as well in a circuit, a couple of days ago. I did the breech and 28 weeks there. And even the candidate didn't look at that it was 28 weeks. And then I laughed. I said, I wasn't wrong. Like I wasn't at a big, huge fault that I didn't notice because you haven't noticed. So this can happen. This is very natural because your focus becomes on the breech. If it says placenta previa or something, your focus becomes tunnel vision. So please look at the rest of the things as well. You might easily miss other important things. You might easily miss the gestational age column or something like that. Okay. Yes, girls. So be ready for this exam, and hopefully, inshallah, you all will pass.